Hi, good evening, everybody. Thank you for attending our webinar. So today we are talking about the PIMS TS MIS in children, post-COVID infections. It's a pediatric inflammatory multisystem syndrome, temporarily associated with SARS coronavirus 2, and same other name for this one is multisystem inflammatory syndrome seen in children. So US CDC abbreviation for the PIMS TS is MISC. So myself, Dr. Satyanarayan Reddy, Consultant Pediatric Intensivist at Rainbow Children's Hospital, Vikrampuri. So going to the introduction, since last 1.5 months to 2 months, we are seeing a lot of children presented to our emergencies with this pediatric multisystem inflammatory syndrome. So as we all know, most children in coronavirus infections are exhibit mild symptoms or asymptomatic, but there are small number of children who are developing the significant systemic multi-inflammatory response. So similar conditions like, as we all know, Kawasaki disease, toxic shock syndromes, bacterial sepsis, macrophage activation syndrome, and now we are seeing dengue shock syndrome children. So these are all can present similar way. So if you have a high suspicion, if you are thinking of this PIMS TS or MISC because of the now because of this pandemic post-COVID, then we can suspect and we can proceed and we can do better management. So coming to the definition, so any child who is having fever more than 3 days with any two of the following, like rash, bilateral non-purulent conjunctivitis, any mucocutaneous inflammatory signs, hypotension, features of myocardial dysfunction, pericarditis, valvulitis, coronary abnormalities, evidence of coagulopathy, and acute gastrointestinal problems. So most common presentation is lot of children presented with vomitings, diarrhea, and abdominal pain, followed by persistent high fever, came to emergency, landed up in shock. This is the common presentation of PIMS TS we are seeing at our emergency. And there should be a associated laboratory collaborations like elevated markers of inflammation, high CRPs, PCTs, D dimers, ferritin, LDH. And one more very important thing is it is a diagnosis of exclusion. So there is no other obvious microbial cause of inflammations like bacterial sepsis, streptococcal toxic shock syndromes. So this, and now as I mentioned, this dengue. So we have to rule out all these common infectious causes which can cause similar multisystem inflammatory syndrome before coming to the conclusion of it has a PIMS TS or MISC. And there should be evidence of COVID-19, either RT-PCR positive, rapid antigen test positive, or serology positive, or likely contact with the patients with the COVID-19. So catch here is what is likely contact means. What is epidemiological definition of likely contact with COVID patients? So this is the definition of the likely contact as per the WHO. They are saying any epidemiological link to SARS-CoV-2 infection is defined as a child with any of the following criteria: either positive RT-PCR or positive COVID IgG antibodies, or any preceding illness resembling COVID infection in such a child, or close contact with confirmed or suspected COVID-19 cases in last 4 weeks. So this is little bit like very difficult to get this history of the like contact with suspected COVID cases in last 4 weeks. As we know, so crowded Indian population is very huge population, crowded population. So lot of them are uneducated. So actually, if you ask, that lot of people may not give proper history of this contact with the COVID cases or suspected cases. Confirmed cases, yes, they can give. Suspected cases, contact history is very difficult to obtain in last 4 weeks. So prevalence, like as per some study by Borragamo at the Italy, so they said it's not actual predicted prevalence, but they calculated based on the coronavirus infections and how many patients they are landing, patients present with PIMS TS. They said it is roughly 1 child in 1,000 infected coronavirus infections may develop Kawasaki-like disease. So coming to the clinical spectrum, so most common way of the clinical spectrum in PIMS TS coronavirus infections is COVID-19 without exaggerated immune response, like there might be some mild symptoms. So like any cough cold, any URI symptoms, any gastroenteritis, loose motions. So there may not be any serious manifestations. So mild symptoms is the most common presentation, then followed by febrile inflammatory state, FIS. These are the children, they might have few symptoms like mild elevation of the transaminitis, mild elevation of the inflammatory markers, fevers, headache, fatigue. So, but they won't have any multisystem involvement, or neither they will have any shock presentation. So other presentation is COVID-19 associated Kawasaki-like presentations. So these are the children who can fit into complete or incomplete Kawasaki disease, but obviously they also won't have it, they don't have any features of shock or multisystem involvement. So coming to the today's discussion, COVID-19 associated MISC. These are the children, they might have a multisystem involvement. Multisystem involvement means 2 or more systems involvement and plus presented with shock manifestations. So coming to the pathophysiology, so in PIMS TS pathophysiology, it is mainly depends upon 2 things. First thing is viral load, and the second thing is host response. So host response is individualized. It depends upon the ethnicity and racial background. So that's why there are some countries like Western countries, UK, even between UK and US also there is a mortality difference, and there is a prevalence difference. So Asian countries, especially India, we don't know what is the actual prevalence, and data is very limited. So this viral load and host response is the determinant factors of the how many children are who are the children who can go into the develop multisystem inflammatory response syndrome. So when there is a low viral load, obviously if the host responses are good, even host responses are not good also, sometimes they might clear their virus. But once if the viral load is very high, there comes the role of good host response. So good host response is like good interferon response, and because of this, if you see this peak interferon response, so because of that, viral load clearance will be very big, and that's why this cytokine storm will be delayed. So it's the interferon response from the host that is the determinant of the or predictor of the children or adults going into the, especially children going into the multisystem inflammatory syndrome. Like there will be delayed interferon response and slow viral clearance. That's why those are the children, they are prone for the multisystem inflammatory syndrome. Coming to the laboratory features, most of them, 100%, all of them will have a high CRP, high DMRs, D dimers, and ferritin, hypoalbuminemia, lymphopenia, neutrophilia, abnormal fibrinogen less than 100, and absence of other potential causative organisms. Some children may have acute kidney injury, anemia, coagulopathy, high IL-10, IL-6 levels, proteinuria, raised CPK levels, LDH, triglycerides, troponin, proBNP, thrombocytopenia, transaminitis. So most important investigation, if I would say any child presented with PIMS TS or MISC, the 2D echo and ECG are very important. So 2D echo, we are seeing pancarditis features, like there might be a myocardial edema, myocarditis, pericarditis, pericardial effusion, as well as valvular regurgitations, coronary artery abnormalities, coronary artery prominence, and definitely some of the children are going to the cardiac dysfunction and shock manifestation. So 2D echo at the initial diagnosis is very important. ECG is showing arrhythmias, conduction abnormalities. I will show the proper ECGs at our center in the later presentation. And they might have myocarditis pictures like strain pattern, low voltage QRS complexes, ST wave and T segment changes, inversion of T waves, QT prolongations, and chest X-ray because of the failure of the cardiac CCF. These are the children, they might have pleural effusion and some infiltrates. Coming to the treatment, American, I'm going to tell about the, I'm going to just read about the American College of Rheumatology guidelines for the treatment. So a lot of guidelines are there. I'm describing these guidelines now. So it's a treatment is a multidisciplinary approach. So you need a good pediatrician, pediatric intensivist, cardiologist, nephrologist, neurologist, and lot of other nursing staff. So this is where this multidisciplinary approach is very important in treating these children with any multisystem disorder, in fact. So initially in cardiology, as I said, 2D echo, getting ECG at the time of admission to see any conduction abnormalities, and round the clock cardiologist backup is very important. So ACR, as per the ACR guidelines, we have to do ECG at the time of diagnosis, and if there are any changes, we need to frequently follow with the ECG followed by echocardiograms as well. Echocardiograms, they say, based on the clinical follow-up, and as well as you have to repeat minimum of 7 to 14 days and 4 to 6 weeks after presentation. And what are the things you have to look at? Definitely, how is the cardiac contractility, ventricular function, and coronary abnormalities. And one more very important, as per these guidelines, is doing cardiac MRI. Yes, that might be the, like nowadays we are seeing the picking of the myocarditis. There is some MRI, recent guidelines says MRI can pick up especially gadolinium enhancement contrast. So this gadolinium contrast is one of the gold standard to pick up the early myocarditis. Of course, gold standard is a biopsy. That is not practically possible. That's why we are relying on the latest guidelines are saying doing cardiac MRI to pick up the early myocarditis definitely useful. Like T1, T2 imaging, mapping, and gadolinium enhancement contrasting. As well as if there is a distal, any coronary abnormalities, distal coronary artery abnormalities, we may not pick up it on the 2D echo. So cardiac CT might help, and contrast enhancement we can see to pick up the distal coronary artery abnormalities. So next important treatment modality is immunomodulated drugs. So IVIG, steroids, biological agents. Agents, anakinra and tocilizumab. So ACR guideline says after evaluation by specialists in a child with MISC. So any child with mild symptoms may require just close monitoring, may not require immunomodulatory treatment at all. Similarly, they are saying there is no added advantage if we start like intravenous immunoglobulin early. Is it prevent coronary artery aneurysms? No. So this panel says there is uncertainty about the empiric use of the intravenous immunoglobulin. As well as the next modality will be the, if the patient is affordable, best treatment is definitely IVIG in Indian setup where there are financial issues. So we can try the next modality is glucocorticoids. Among the glucocorticoids, methylprednisolone as well as the dexamethasone, any one of them can be, prednisolone can be tried. So, and similar way, you can start with low to moderate dose glucocorticoids. It depends upon the inflammation. It depends upon the underlying child condition, shock presentation, as well as multisystem involvement. If there is shock presentation, multisystem involvement, and if the children are having LV dysfunction, definitely it is preferable to go for pulse dose. So pulse dose, they are saying there is a recovery trial I'm going to describe later on. So as per that also, we can start with 10 mg per kg. We can go up to 30 mg per kg. If there is shock, we can give IV pulse dose methylprednisolone. So shock with requirement of inotropic support. And if there is no response to IVIG or methylprednisolone, the next line should be any MISC clinical children with inflammation. The inflammatory markers are not responding to the, not declining with the IVIG steroids. We can try biological agents. So anakinra versus tocilizumab. So I'm going to describe. So anakinra versus tocilizumab. So this guideline says anakinra is definitely preferable than the tocilizumab. The reason is anakinra, there are less chances of any superadded infection. But with the tocilizumab, the major problem is there is a high risk of potential risk of bacterial and fungal infections. So there should be risk versus benefit weighing. So it is as per this article, anakinra is preferable compared to the tocilizumab. There are few guidelines saying tocilizumab may not be showing good results. So, but personal experience, we have used one child who had coronary artery giant aneurysms not responded to the IVIG's second dose. First dose, no response. Second dose, another 2 gram per kg, no response. Then in that child, we give steroid, methylprednisolone, no response. We have to use tocilizumab. Till now, the child is febrile and responded to tocilizumab. This is our experience. Coming to the antibiotics, as we know, all these are viral infections. We can use any broad spectrum antibiotic. Most important thing in antibiotic usage, especially in Indian setup, is get the cultures. If the cultures are sterile, we have to de-escalate the antibiotics. Anticoagulation. Anticoagulation, aspirin, enoxaparin, dalteparin. So these are the three things. Most commonly used is definitely all of three. Dalteparin is not used in our setup. We have used aspirin and enoxaparin. So there is a prophylaxis versus treatment. So when should we go for prophylaxis? When should we treat a treatment dose of the enoxaparin? So ACR guidelines says low dose aspirin is enough. There are some guidelines saying that high dose, like up to 12.5, up to 30 mg per kg as well. But it depends upon the inflammatory response to the, if you are using simultaneously steroid, yes, it's okay to use low dose aspirin. Of course, if the child is responding to the pulse methylprednisolone, low dose aspirin, and we are following regularly with the inflammatory markers, if they're going down, that's okay. If the inflammatory markers are still persisting, then we can use more higher dose aspirin, like 12.5 mg to 30 mg per kg also. Even if there are coronary artery abnormalities, we have used up to 80 to 100 mg. AHA guideline says, American Heart Association guideline says, we can use, if the coronary artery aneurysms are there, we can go up to 80 to 100 mg per kg per day till the inflammation settles, till the child becomes febrile, till the CRP, ECR goes down. Then later on, we can follow the low dose 3 to 5 mg per kg per day. It depends upon the, maybe up to 6 months, 3 months, depends upon the repeat 2D echo. But when should we start enoxaparin? So Z score on coronary artery aneurysms are very important. If the Z score of the coronary artery aneurysm is 2.5 to 10, we can start with low dose aspirin and therapeutic anticoagulation like enoxaparin or warfarin. But if there is any documented thrombosis, ejection fraction is less than 35%, then we have to start at least therapeutic anticoagulation with enoxaparin up to 2 units per kg, up to at least 2 weeks. Even from after discharge from the hospital also, we have to continue the enoxaparin on OPD basis. This guidelines is on anticoagulation from the consensus based on the anticoagulation in hospitalized children from the European consensus. So as per them, any child who has a D-dimer more than 5, upper limit, normal limit is 0.5. If it is more than 5, it's more than 2.5. Hospitalized children, COVID-19 related illness like MISC, we can give anticoagulation, prophylactic anticoagulation. So therapeutic kit, it depends upon the Z score as well as the thrombosis. So if hospitalized children, if they are asymptomatic, if there are symptoms, yes, MISC, we have to start prophylactic and enoxaparin. If they are asymptomatic, D-dimer is more than 5. But if there are like certain criteria like hospital-acquired risk factors for the hospital-acquired venous thromboembolism, like what are the risk factors for hospital-acquired venous thromboembolism? Most common risk factors are putting central line. Any child comes to ICU, if the child is sick, then we need to put a central line. We need to ventilate the child. We may need to give sedation, muscle relaxation, because the child will become less mobile. So all these factors will contribute to the there is a risk of the hospital-acquired venous thromboembolism. If there are one or more risk factors in hospitalized children with MISC, we can give prophylactic and enoxaparin. If there are no such risk factors, we may not give. No need to give. If the hospitalized asymptomatic children, if there is risk factors or multiple risk factors, still we can consider giving anticoagulant thromboprophylaxis. If there are fewer non-risk factors in non-COVID patients, there is no need to give any anticoagulant prophylaxis. So other specialty, multi-specialty review will be like if there is any same MIC children having acute kidney injury, seizures, encephalopathy. So we need to have an opinion of the nephrologist, neurologist. Coming to the gastroenterology opinion, so we are seeing in two of our patients with MISC, pancreatitis is rising trend. There is one patient who has a lipase of 6,000, amylase of 11,000. So we took the opinion of pediatric gastroenterologist with conservative management only, child setting. Immunizations. So immunizations is very important. We should not skip, as well as in a child with MISC who received IVIG, methylprednisolone. So definitely we should write down in a document. We should document. We should tell the parents there should not be any live vaccines in next 6 months, any killed vaccine in next 3 months. This is very important, as well as annual influenza vaccination is important among the children who admitted with MISC who received IVIG. And advice on returning to school. CDC says even like whoever is got infected with the coronavirus infections, so next 3 months they might have coronavirus like infection still persisting, maybe excreted in the saliva, stool, and urine. So definitely 3 months they might be, but it doesn't mean that they are infected. They might have the virus. The dead virus might be there. Usually after 14 days of the asymptomatic period, they may not be infected. But it doesn't mean that once you, of course, schools are not there now, but if at all any reopening happens, it doesn't mean that after 14 days, if you go to school, you can mingle with you should not, you may relax on the SMS practices. No, even once you are recovered, even asymptomatic, it is mandatory to follow the SMS practices at any gathering, not only school, at any gathering, like social distancing, wearing mask, and sanitizer, usage of the sanitizer. So these are very important. So recovery trial, pediatric specific modification is like they are saying, as I said, methylprednisolone 10 mg per kg for 3 days. As per this recovery trial, they are saying if you give for 3 days, there is no need to go for weaning of the steroids. But most of the times we'll end up in like prolonged usage of the methylprednisolone, maybe up to 5 days. So other guidelines like RCPCH guidelines are saying it's better you should follow the weaning taper of the over next 2-3 weeks steroids. In recovery trial, as per this, less than 44 weeks, infants corrected gestation days. So what are the treatment options available? Hydrocortisone, azithromycin, and convalescent plasma. Coming to the convalescent plasma, so lot of recent trials are saying there is no much benefit of the convalescent plasma. The reason is this antibody-mediated contribution to the pathogens of PIMS and safety of the convalescent plasma. So as per the recovery trial, if the children, PIMS TS or MIC children, not responded to the IVIG, steroids, and biologic agents, like in the procedure, we can consider giving the convalescent plasma still. So as per them, adults, there are no any safety concerns till now with the, whoever is treated with convalescent plasma. So next few slides, I will talk about the Western data followed by our institute data. So as per the CDC data, MMWFR data, mortality morbidity weekly report, as of July 29, 2020, a total of 570 MIC patients were reported among all states of the USA. Of that, most common median age of the presentation of MIC is 80 years, ranging from 2 weeks to 20 years. And predominance of the males, 55% of them are males. And obesity is the major comorbidity. Coming to the clinical features, among the 570 patients, most of them have more than 90% are gastrointestinal, then next followed by cardiovascular, next dermatological and mucocutaneous involvement. Dermatological, like any, as we see in any Kawasaki-like presentation, like edema, rash, and cracked lips, strawberry tongue. All these things can be seen. Complications wise, most common complications are cardiac dysfunction, shock, then followed by coronary artery dilatation and aneurysms, then acute kidney injury. Out of this 570 patient COVID-19 testing status is, they have all of them, 99% have either RT-PCR or serology positive. 46% have only serologic evidence. 25% have RT-PCR positive, and few of them have mixed both. 5% did not have any testing, and they have epidemiological link. Epidemiological link, as I described earlier, any contact when is suspected or confirmed case in past 4 weeks. Treatment wise, 80% of them received IVIG, next followed by steroids, and 58% received antiplatelet modification, and then 44% received anticoagulation, and 40% above 40% required inotropic support, and mortality is 1.8%, 10 out of 570 children. This is from the UK multi-center observation study from the UK data. From the May to April 1st to May 20th. This is the data from the all across the 21 of 23 PICUs in the UK. As per them, 78 cases were reported. Median age is 11 years. Male patients are 52. Again, 67% is male predominance. Most common clinical feature is fever, followed by shock, abdominal pain, vomiting, diarrhea. Again, GI symptoms. Treatment, 40%, above 45% required ventilator, and 83% required inotropic support. 70% received steroid, 76% received IVIG. UK, compared to USA data, they are using steroids and IVIG is almost similar. In USA, IVIG is more used than the steroids. 22% received biological therapies, and 36% have evidence of coronary artery abnormalities. 3 children were on ECMO, and 2 children died. 2 out of 78. Again, mortality similar to some 1.8 to 2%. Coming to our center experience, our center data, we have a total till now, since last 1.5 month to 1 month, we are seeing 1 to 2 cases per week presenting with to our emergency with PIMS TS or MISC. Total 17 patients we have seen till now. Out of this, 2 children were febrile inflammatory state, diagnosed on OPD basis, doesn't require admissions. And then five of them are Kawasaki-like presentation, MISC. And the 3 plus is, these are 3 children who have with MISC presentation. So here is a little differentiation is there. MISC post-COVID infection, like that means lot of children, they are not even aware of whether they got COVID infection or not. If you ask history, any contact, nothing they are giving. But if you do COVID test, they are coming, it's coming positive, and with symptoms of multisystem inflammatory syndrome. But there is other presentation is that is in fact more mortality. Like we have one child who although he went lama, and later on we found out the child was succumbed to illness. So these are the children like COVID PCR positive, and then because of the host delayed interferon response or host response, dysregulated immune response. So they are going to this multi-system inflammatory syndrome. So I mean to say, COVID positive continue to have a same spectrum. In the same spectrum, they are going for the if they are going to the multi-system presentation, those children are definitely have a higher mortality compared to the post-COVID MISC presentation. So COVID-19 testing status in our center is MISC and COVID-19 antibody positive are 7, and MISC RT-PCR positive antibody negative are 2, MISC PCR and antibody positive are 2, and number of patients with KD-like illness with antibody positive are only 1, and KD-like illness with antibody negative are 4. So this FIS antibody positive are 2. This KD-like illness, lot of them are, we have a total of some 5 patients. Out of 5, antibody test came positive, only 1. All remaining 4, they didn't have an antibody positive, but suddenly we are seeing the surge of the Kawasaki disease-like presentation in the last 1.5 months. So we took the opinion of our cardiology team also. So they are also getting same presentations. These are the children. This time we have seen before corona pandemic Kawasaki disease, but this coronary arterial dilatations are compared to before corona pandemic. Their sizes were definitely, Z scores were lower side. Now after this corona pandemic, whatever the Z scores we have, as per the cardiologists, they are saying definitely higher score. Few children have more than 10 and giant aneurysms they are seeing. So even though COVID IgG positive negative, still we have to consider it could be a post-COVID like KD presentation. Coming to the age and sex characteristics, males, again, male predominance at our center also. Males were 12, females were 5. Median age of presentation is 18 months. In KD-like presentation, children we are seeing less than 5 years. MIC presentation, we are seeing children more than 5 years, especially adolescent, more than 8 years, obese children, male children. These are the most common age presentation we are seeing in MISC. FISC, we have 1 child 5 year, 1 child 3 year. Comorbidities, obesities. Out of these total 17 patients, we have 1 child with TB meningitis and fructose 1,6-bisphosphatase. These two are TB meningitis child had both COVID RT-PCR positive and antibody positive. This fructose 1,6-bisphosphatase child has RT-PCR positive. This child came to us, is a known child diagnosed at our center only, fructose 1,6-bisphosphatase with some fever without focus, went into multi-system involvement and shock. We did as a mandatory protocol because of the corona pandemic, we did RT-PCR and antibody both. RT-PCR came positive. Child went into shock, requiring multiple inotropic support. We started on the steroid, IVIG, but respiratory distress worsened, cardiac dysfunction worsened. So we had to ventilate the child. And MRI, I'll describe the MRI later on. This child went LAMA, but ultimately he went to, we found out on follow-up, the child was succumbed to illness. So coming to clinical features, so around all of them have a fever, then followed by hematological manifestations like lymphopenia, neutrophilia, raised CRP, PCT, high D-dimers, and coagulopathy. So most of them have a hematological manifestations, followed by next come the GI symptoms, vomiting, diarrhea, abdominal pain, transaminitis, mild, or if there is severe inflammation, then moderate to severe high levels of SGOT, SGPT, then followed by cardiovascular, then dermatological mucocutaneous. Here we have 1 patient with, we had one child with acute kidney injury and encephalopathy, 1 patient. So one child required mechanical ventilation, 3 children were managed on HFNC, 6 children required oxygen, and 3 children required inotropic support. And at our experience, because of, like as I mentioned earlier, so we used definitely close monitoring, and we followed inflammatory markers, CRP, ESR. So we started, our preferable immunomodulator therapy was steroid, definitely compared to IVIG because of the financial issues. So a lot of them, like the children who are not developed coronary artery abnormalities, they responded very well to steroids. But the children who had coronary artery aneurysms, definitely we gave IVIG. So these are like the children with coronary artery abnormalities, IVIGs has to be given. As I said, like some children has not responded to the first dose, we had to give second dose of IVIG, another 2 gram, total 4 grams. Then still no response, developed giant aneurysms, required the steroids, and then followed by high dose aspirin and enoxaparin, as well as further requirement of, we gave for 1 child, we have to give tocilizumab as well. Anticoagulation, we used enoxaparin and aspirin of based on the consensus from the European consensus. 11 patients we gave anticoagulation. These are the few echocardiographies of children with coronary. You see right coronary artery definite enlargement, and this measurement we are doing. And LMCA, LAD, anti-descending artery, main circumference left, both are dilated. This is the ECG of the one child. This child has a splinter QRS complexes or fragmented QRS complexes. So so I also reviewed the literature. So it is a sign of whenever there is a scar on the myocardium, like because of the myocarditis, corona-induced, COVID-induced myocarditis. So definitely, whenever there is a ischemia and perfusion problems, there will be conduction abnormalities. That's why you will see splinter hemorrhage, splinter QRS complexes. One more child. So this child is typical myocarditis picture, like abnormal QFs in the lead 3 and AVF, and poor RV progression, low QRS complexes, QRS voltage complexes. And for this child, we repeated the 2D echo after giving the steroid. After 2 days, nice, good, normal voltage QRS complexes we saw. I didn't have this ECG. I could not get. So there's one child, you see valvular regurgitation, TR check. So this child, pleural effusion. And this child, severe LV dysfunction. You see, there's hardly any movement of the left ventricle, hugely dilated left ventricle. And we have a like chilblains, few children presented to us with gangrenous changes. These are the gangrenous changes. This is what fructose 1,6 bisphosphorate child I was telling. Like this child has a typical acute leukoencephalopathy with restricted diffusion manifestations on the MRI. So if you see, there's a both gyral and subcortical diffusion restriction on the all over the all side, both bilateral. It is a diffuse restriction, which is corresponding to the ADC mapping. So this is actually for this child, RT-PCR came positive. We want to send to we sent viral PCR, comprehensive viral PCR, CSF viral PCR, which was negative. We requested to do in CSF for the SARS-CoV-2 virus. They could not do it. Like we want to see any association of the coronavirus with this MRI picture. So we could not get it done. So coming to the final slide, take-home message is definitely, if you think of it, then only we can identify it. So high suspicion. From now onwards, maybe more cases we may get. So the reason is, if you suspect, then we can early diagnose. If you start treatment early, till now we don't have any mortality. All of them responded to the, except that one child who had this COVID with some comorbidity, fructose 1,6 bisphosphatase. All of them have survived. And the OPD basis, any child who comes to you fever more than 3 days without focus, you have to think of now PIMS TS or MISC. And obesity is one of the major comorbidity. And any child with Kawasaki-like illness presentation, we have to think of going ahead with doing testing for COVID IgG and RT-PCR testing. So thank you all. Any questions? Thank you for patient listening. If there are no questions, we can end the session. Thank you.